Welcome to Save Your Thyroid, a podcast all about thyroid nodules. My name is Jennifer Holcomb, and I advocate for fellow patients suffering with this very common condition. Thyroid nodules impact 70% of adults in their lifetime, and the standard of care is surgical removal of half or all of the gland. But in recent years, safe and effective non-surgical treatment options have become available. In this podcast, I sit down with patients and physicians to discuss life with thyroid nodules, treatment options, and how to save the thyroid whenever possible. Today's guest is Dr. Jonathon Russell. After training at the Cleveland Clinic, Dr. Russell trained further at Johns Hopkins before spending almost 10 years there. He became the chief of head and neck endocrine surgery at Johns Hopkins and was the director of the Thyroid Tumor Center. During that time, he was the first surgeon to complete transoral robotic surgery for thyroid cancer and led the largest series of transoral surgery in the West. He was the first group of head and neck surgeons to offer radiofrequency ablation. He is currently the president of the North American Society of Interventional Thyroidologists. In 2024, Dr. Russell founded the Russell Center for Endocrine Health, where he continues to innovate as he offers each patient a personalized plan of care. Today's conversation centers around the topic of thyroid RFA and insurance coverage, specifically a CPT billing code that has been created by the CMS. For the past 5 years, many patients have been eagerly awaiting the creation of this code so that they can pursue treatment with the benefit of their insurance coverage. The new code was just released, but unfortunately has set the value of reimbursement too low for RFA to be financially sustainable in the outpatient clinic setting. In today's episode, we'll discuss what this could mean for the future of thyroid RFA, as well as actionable steps you can take to advocate for the future of this non-surgical treatment option. Dr. Russell, welcome back to the podcast.
Hi, Jen. Good to be back.
Thank you so much for coming. So a lot of us already know who you are. You've been in this space for a long time. But for anyone who doesn't know you, please take a minute and just tell us a little bit about yourself. You've been at Johns Hopkins for a long time, and now you're in private practice, and you've been doing RFAs and surgeries. And so just kind of give us a rundown.
I'm happy to, but really we need to talk about what you have done since last time we talked. You've gone crazy. This is fantastic how the Save Your Thyroid movement is really kind of just grown so much. And I think it speaks a lot to you and what you've done, and just the fact that you're helping so many people. And it speaks to how important this topic is and how relevant it is to everybody. So first of all, good on you. You've done a lot more exciting things than I have since last time we talked. But yes, I have done some exciting things too. So I was at Johns Hopkins for 10 years. And in the last year, I've transitioned out of Johns Hopkins into the Russell Center for Endocrine Health is what it's called. The reason that I did it is it felt like I was so super busy doing surgery. I kind of became the guy in this part of the world that did most of everything, kind of from advanced cancer to small cancer to benign stuff to Graves' disease. And I was so busy just doing surgery that I didn't have time to carve out some of the things that I think that the field is growing into, meaning a lot more minimally invasive stuff in general and just some super cool things in the pipeline. And I could see a place where I was just going to be busy and just watch the field evolve away from me. And so Russell Center for Endocrine Health is hopefully able to stay at the front of all of those things. And really, it's been really fun to just have a very personalized product with every single patient. There's no call center that you have to worry about. You can get you right in. We talk to you right away. It's been really fun.
I saw your Instagram post about that the other day. I thought that was so awesome that you did that. For anyone watching this who hasn't followed Dr. Russell on Instagram, he actually called Johns Hopkins asking to speak to Dr. Russell, and you said it took 30 minutes to get through.
31 minutes I was on hold for. They have very peaceful call music. It was so it was great. I just did work on my computer, but it was 31 minutes before a person talked to me.
Yeah. That's wild. Yeah. So at your new practice, you've got definitely better access for the patients that are trying to reach you is what the goal of that post, I'm sure, was to let everyone know. So that's amazing. I'm so excited to hear how things are going with your practice. So let's get into the meat of today's conversation. You and I are going to talk about something today that I think, unfortunately, is not the happiest of news for patients and for doctors too. And so let's just get right into that and I'll just let you start that conversation.
Yeah. Radiofrequency ablation was kind of the front tip of the spear, but minimally invasive thermal ablation techniques are clearly just they're growing so quickly in the United States. Lots of adopters, lots of patients who are interested. You're over 11,000. You've got your new website. That comes because there was a gap in what doctors had been offering patients, right? We didn't have all of the tools to take care of kind of that space in between. I've got a problem, but it's not bad enough for surgery. There were a lot of patients in that gap. And all of a sudden, we have something to offer those patients. Well, CMS, Center for Medicare, is really the driver of how healthcare is paid for in the United States. And they are the ones that control whether or not a code is paid for, or rather a procedure is paid for by insurance. And one of the things that you and I have talked about, you've talked about it on your podcast, and I know on Facebook, you're helping patients with this every single day. How do patients get paid back for doing radiofrequency ablation? And there hasn't been a good way to do that until we get a code from CMS. That's kind of how insurance companies know what you did as a doctor.
Right.
And we were all waiting for CMS to finally do it. I submitted something to about 3 or 4 different societies 5 or 6 years ago working on this. Tim Huber is the next president-elect of NASIT, which is the North American Society for Interventional Thyroidology. He's an interventional radiologist in Maine. And he has been kind of helping to lead this project since NASIT was founded. And we've all been like working with the AMA and all of these groups to do it. And finally, it came to a culmination. CMS told us this year, hey, we're going to give you a code. And when they give you a code, what they do is they give you a relative value unit for how much they think it costs a doctor to do that procedure, and therefore how much they're going to reimburse it for it.
The point of this code that's so important, and a lot of patients know this, but some don't, is that you have to have this billing code to submit to the insurance for them to know how much to pay. If they're, so a lot of the patients, they'll file insurance, and then the insurance company will say, well, there's no code for this. Or the code that was submitted, which we've been using for the last 5 years, 60699, is this just general endocrine procedure code. So there's not a fixed amount attached to it. So the insurance company will either decline and say, this is experimental, we don't cover this procedure, or not enough information. And, and then it just starts this whole back and forth between the patient and the insurance company and the doctor. And it's frustrating.
But that 60699 code, you're right. It just means essentially we don't know what this is. That's the same code that we use for scarless thyroid surgery, scarless parathyroid surgery, for a scarless thyroid with a neck dissection, for radiofrequency ablation, for cryoablation, for nanopulse. It's the same code for everything.
Wow. I did not know that.
Yeah. It's just like here you go. It's just the wastebasket code. Okay. And so when insurance companies get it, each time they have to decide. And that's why you've talked to patients who sometimes their insurance company has paid $30,000 to do it, and other times they haven't paid at all. Anyways, and so that's your patients and my patients have been stuck in this for the last half a decade now, trying to figure out what they can do. Well, CMS finally said that they were going to give us a code, and we all waited anxiously, and they did surveys and they talked to a whole bunch of different societies. And at the end of everything, they came back and they gave us a relative value unit of 5.75 RVUs. Approximately, they consider it less work on the part of a doctor than a consultation with the patient. And if you
any sense.
Well, I kind of agree with you. A lot of us agree with you. But in general, like if you turn it into dollars, doctors get paid somewhere between 30 to 70, usually $30 to $70 per RVU. Okay. And so if you're a top end doctor, that means you'll get paid $350 for doing radiofrequency ablation.
That's not anywhere near enough money.
No. Well, I mean,
for a lot of reasons, which I'll let you go into that. But the primary reason, which I can say, and a lot of patients probably know, is that it costs more money to do RFA by far than that amount of money.
That's the primary reason, right? Okay. Like it's at the end of the day, you go into medicine not because you want to make money, but because you want to help patients. At the same time, it's hard to financially stay solvent when you're losing $1,000 per patient, plus or minus.
Yeah.
And so CMS did bake in some extra things into that to account for that. And they have some extra cost that is allocated for the electrode and some extra cost that's allocated for the facility. But then you start to get into really what a lot of us think are the primary problems. Oh, and they did allocate extra funding if you do a RFA on the other side.
Mm-hmm.
But we're going to dig into all of this stuff.
Yeah.
But one of the things that has been so great about RFA is that it's pretty democratic. That you can find an RFA specialist in most places around the country within a relatively short period of time since this technology came onto the scene. And you might have to travel a few hours, but it's a lot better than just one or two places in the country.
It's so much better in the last 5 years. It's grown so much. I mean, there's around 150 locations in the US, which is tremendous because in 2019 there were 2. So anyway, continue.
Yeah. So one of the things you and I talked about recently was the really nice thing about it is usually the person who's doing your RFA is the person who's going to follow up with you as well. They're either a surgeon or an endocrinologist, usually, who has a lot of experience with thyroid pathology. And so they're going to know how to check your labs, and they're going to know what things look like. They're going to know how to manage a complication. They're kind of invested with you as a person. Mm-hmm. But when CMS went through with this CPT code, they allocated the resources in a way that is favorable towards doctors that perform lots of these procedures in a hospital setting. And all of us have gone to a hospital, and we've all had that facility fee charge that comes afterwards. Mm-hmm. You pay the doctor the copay, and then you get an extra few $100s tacked on for your facility fee charge. Mm-hmm. Well, as CMS was doing this, they kind of have preferentially favored people going into big hospital facilities to do this instead of in your local doctor, where it's kind of, I think, preferable to have the procedure done.
I think a lot of patients would prefer that, truthfully. I mean, I had a great experience having RFA in a hospital. It is way more expensive, but going into it, and I've seen RFAs done in private clinics. It's way less stressful. It's just way less everything. It's less involved, and it's less cost. So this whole preferential towards a hospital setting, it doesn't really make a lot of sense, and it's not in the best interest of the patient or in the majority of physicians who are doing RFA who are in private practices and small clinics. Well,
and even the doctors that we all talk about in academics, like most of the time we've all shifted, even though we have a hospital setting that we could do it in, we recognize the cost is lower and the product is better if we do it in the outpatient clinic because we have everything we need. And it's not, the stuff isn't big and bulky, and we can do it in a clinic, and it's just so much easier. You don't have to pay for parking. You just walk right in. You've got everything that you need, and you know your doctor. You're going to see them for follow-up afterwards. It's interesting. We talked again about how CMS did the same thing with fine needle aspirations about a decade ago. That if most of your patients, I think you were one of these people, has had biopsies, been following a thyroid nodule for a couple of decades, and the first time you went in for a biopsy, you went into your ENT or your endocrinologist, whoever, and they did a biopsy right there in clinic during your visit. It took 10 minutes. Everything was great. About 10 years ago, CMS decided we're spending too much money on this. Let's make it cheaper. They cut the reimbursement. They said that they would only pay for one at a time, and they added an extra facility benefit on there. And the long and short of it is, any of your patients who have had a biopsy in the last 10 years, probably most of them have been told, hey, you should go to see an interventional radiologist at a hospital setting to have this biopsy be done, because interventional radiologists have the facility fee add-on that actually makes it financially viable for them. And so what we're worried about happening, North American Society for Interventional Thyroidology, NASIT as a society, and then all of the others, ACE for endocrinologists, American Head and Neck Society, AAES, all of these societies have all sent in letters to CMS saying, hey guys, what you're actually doing is going to hurt patient care because you're going to move it out of the clinic, out of the patient-facing person, and put it into an IR suite, which is more expensive. And that person doesn't usually have a lot of experience with thyroid pathology. And even if they do, they're not generally going to be the person who's following up with you on a regular basis. So
it's not in the best interest of patients. And it's like we're taking a giant step backward. So I feel like this was not what we were hoping for by far. You know, we were all very hopeful that that the procedure code for RFA was going to make it so that RFA would be more accessible and RFA would be less expensive. And this is doing the exact opposite. It's going to de-incentivize these clinic-based physicians from offering RFA if they can't afford to provide it. And then it's going to also make access to care less available to these patients, especially the ones who were deciding, okay, I don't want to have surgery, so I'm going to wait for this code and let insurance cover my procedure instead of having surgery, because so many patients have to make that decision. They don't want surgery, but it's at least covered by insurance. And so this is a huge blow to all of us in this community, and I'm so disappointed. There was something we talked about that I wanted you to talk about, treating both sides of the neck at the same time, being encouraged by this to kind of set this up. It is generally not advised, if you have nodules that need to be treated on both sides, it is generally not advised that you treat both at the same time. Kind of tell us why.
Yeah, and there's exceptions to every rule, but in general, we don't like to treat bilateral nodules because of the worst case scenario of what could happen.
Mm-hmm.
The risks of RFA and thermal ablation in general are pretty low, but theoretically, you could cause permanent changes in your voice. You could cause hoarseness by injuring the recurrent laryngeal nerve or the vagus nerve. If you do it on one side, it's super unpleasant and you can't speak loud and clear. And I'm sure some of your patients have had this before. It's problematic. You have sometimes when you're swallowing, it feels like stuff gets stuck and you cough, and it's not good. But patients are resilient and they usually do okay. In the worst case scenario, if it happens on the other side at the same time, you wouldn't be able to breathe because the vocal cords would close. And so in that situation, you would need a hole in your neck with a tracheostomy tube in it so that you could breathe through a tracheostomy tube. Given that waiting and staging them, doing them the right side and then the left side, for example, kind of essentially obviates this risk and makes it nearly zero risk of having that happen. Most of us feel like you should only very rarely do bilateral nodules. Now, for a lot of your patients, that is an extra expense, right? And so because my doctor's telling me I have to go back twice. Yes. And this is why, because a tracheostomy is just hard to justify when you could have done something to prevent it.
You didn't mention one thing that my personal experience included, which was swelling, like a great deal of swelling. If you have nodules on both sides, and some patients are very unfortunate to have large nodules on both sides. So if both sides get really, really swollen, that's going to make it really hard for them to breathe in the immediate time after the procedure. So, even less severe than what you're describing, what you're describing are very rare but serious complications. Right. Swelling happens to everyone. So, that's a situation where it's just, I feel like as a patient, I wouldn't want to experience that. So I think it makes sense, to be as cautious as possible in that regard and do one side and then wait a little while and then come back.
Well, we agree with you. Sadly, the new code, we had kind of advocated, hey, if you're not going to pay very much for ablating one nodule, then at least give us a code that'll pay for a second nodule if we do that. And that way, we have a way to be compensated for our time. But the new code actually says you can treat as many as you want on one side. You still only get those 5.75 RVUs. But if you go to the other side, we'll throw in a handful of extra RVUs for that. And so you can see a situation, again, anytime you want your incentives to align, right? You don't want doctors to be encouraged to do something that's not good for their patients. We all want to make this as easy as on our patients as we can. We all sometimes feel like it's far enough away and the nodule on the other side isn't big enough, so maybe we can get away with it safely. We try to do the best we can for patients, but we don't want a situation where CMS tells you, hey, I'll pay you almost as much if you do it at the same time on the other side. Somebody's going to get hurt if we do that.
That's unfortunate. So this is a lot of negativity. Is there anything that we can do about this? Is it too late to take action? Individual patients or as a group of patients?
Well, let's talk about the good first. First of all, we have a code. And this code is just for radiofrequency ablation. So it doesn't apply to laser. Laser has a different kind of temporary code. It doesn't apply to nanopulse. It doesn't apply to anything else. And so maybe we can get different valuations for some of these new codes that are coming out. I would say historically that's less likely that it would be significantly different, but it's theoretically possible. But the big thing is by having a code, now we have something that we can use to say, hey, this isn't scarless thyroid surgery. This is actually radiofrequency ablation.
Yeah.
Makes it much easier to do research so that we can see how many patients are actually having it done. It makes it much easier for us to say, patients who have RFA, how frequently do they need surgery 5 years later? Are we just temporizing a problem, or are we actually curing a problem? What are we doing? And so I think there's a lot of good that comes from the fact that we actually have a code. And yes, there's some doom and gloom, and I think we're appropriately concerned about it, but it's really good to have a code. And so we've been fighting for this for years, like we said. It's also good. There was a period of time that CMS gave everybody to, it was an open comment period where people were able to write in and say what they thought about it. And it was actually pretty satisfying. Between fine needle aspiration and RFA, almost 7,000 responses went in to CMS saying, what you're doing is negatively affecting patients and you need to reconsider this. And I went through and read, I don't know, probably 10 or 20 pages of comments.
Wow.
And they were all saying exactly the same thing and what we're talking about right now. And it was from really well-known doctors and people that you've never even heard of before. And it was pretty satisfying. Whenever everybody is on the same page, we like to think that people are going to listen to that, but we'll see. And there is still the ability, I think you have a couple of websites. There's a website that you can go and you can respond. You can send good old-fashioned snail mail to CMS. They are going to actually announce their final decision sometime before Thanksgiving. Traditionally is when they finalize everything. And so even though the open comment period is closed, they haven't actually decided. If 11,000 people write letters, that can't hurt. That's for sure.
Yeah. I had thought about seeing if we could kind of put together a statement on behalf of Save Your Thyroid, and then also having all of the patients that are willing to kind of write in and do that. So I think that's definitely something we'll try to do. So anyone watching this, I would encourage you to do that. And can you explain what the process of that would be? How do we do that?
Yeah. So there's a specific code that CMS is using. It's like a file number for this case, for the comment about radiofrequency ablation. And if you add that file number in, and then you can email it to, I think it's actually the headquarters for CMS is in Maryland. And so I think if you just write your letter saying, hey, I had radiofrequency ablation. It was really important to me. I'm worried about the valuation. I hope that you're considering that we want this to be available in the community we want this to be accessible to everybody. And we're worried that the proposed valuation is going to negatively impact how accessible radiofrequency ablation is.
Okay. So not the best news, some positive things in there, and then some action we can take. So it's not all doom and gloom. So let's hang on and hopefully maybe see if some positives can come out of this. So, all right, Dr. Russell, is there anything else you'd like to share before we wrap this up today, just to kind of let the community know about yourself or updates in this area that you have on your mind?
Yeah, I'm trying to be like you, Jen. I realize that a lot of patients, there's medical literature is super dense and it's hard for a lot of patients to even get access to it because it's usually behind a paywall. And then if you do get through it, I remember my first year or two of medical school just being like, what does this article even say? I cannot understand any of this stuff. So websites and people like you have done a lot of value. And so I'm trying to do something similar. I'm not as good at it as you are, but we've started the 60 seconds with a surgeon thing on Instagram. But I think one of the things that doctors, we learn so much and we think that things become obvious and we don't do a really good job of explaining the gap between I had a patient come in yesterday whose mom has been managing her Graves' disease for a decade with natural therapies. And this patient was younger and she was coming in to say, hey, what should I do? And she said, oh yeah, my mom's done this and she's been managing it with natural therapies for a decade. And she hasn't seen a doctor. And her eyes are starting to get buggy and she's super skinny, but she loves being skinny. And I think somehow as a medical field, we need to do a better job of saying, hey, in that specific situation, hey, we understand that this is making you kind of feel okay right now, but the long-term consequences of this are X, Y, and Z. And so when you come in and talk to us, you might feel like we're being really blunt to you. And that's because there's a huge body of scientific literature that kind of doing this. And then hopefully we can do a better job of maybe not being so blunt, but still being honest and say our there's so much medical literature behind this that we have to tell you that this is the right thing to do.
Mhm.
And if you're going to do something different, then we need to come up with plans, and we need to come up with maybe bumpers that say, if you get to point X, then we need to do Y. I think as a medical field, especially in the thyroid space, where there's a lot of gray zone, where just like with thyroid nodules, you don't have to treat a thyroid nodule just because it's 3.5 centimeters or even 8 centimeters. Mm-hmm. You have to treat it when the patient wants you to treat it most of the time. Mm-hmm. But there's exceptions to everything, and we need to do a better job of talking to people.
Well, I appreciate that. I think a lot of doctors are getting better at this. You're a good example, of, and I think a lot of patients have mentioned this in the community about, they feel like, first of all, that you and other doctors that do these thermal ablation procedures, these non-surgical procedures, that these types of doctors are more open-minded and they are better at listening to the patient and validating the patient, but also that they communicate better with the patient. And so there's better communication both directions. But this is not something we've seen with physicians who don't do these procedures. It's very common. Patients are very frustrated. They're very jaded. They come to our community and they just think all doctors are out to take their thyroid out and don't care about them as a whole human being. And so I agree. I think in general, there needs to be improvement, but I'm so excited when I meet doctors like you and in this community who just do such a good job at that and are working on that and helping patients with that. So thank you for what you're doing, Dr. Russell. Thank you for this conversation today.
Thanks, Jen.
This has been very helpful.
As a doctor, it's just so much faster if a patient walks in with a thyroid nodule and you say, you just need surgery. And these are the risks of surgery. It's a fast conversation. And I still talk to doctors who are like, why would I want to do scarless surgery? Why would I want to do RFA? It's going to take every 5-minute conversation and turn it into a 30-minute conversation with 3 phone calls afterwards. Yeah. And they're not wrong. That's what it's going to be. At the end of the day, if patients get what they want, then patients start to trust doctors, right? Mm-hmm. And then it gives doctors a place to say, hey, we did this for a long time doing what you wanted. And now I have to tell you as your medical expert, this is the wrong thing to do. You've crossed a line that you need to know that this is when your health is at risk and we have to do something different. Mm-hmm. Anyways, thanks, Jen, for everything that you do. So excited for the growth that you guys have had on all of this. And again, it comes down to you just being willing to listen to people and help people get what was in their best interest. So good job.
Thank you so much. Thanks so much for listening. Please share this content and help others. If you need resources, testimonials, and support, please join our patient community, Save Your Thyroid. You can also find me on social media and Substack under the media handle, It's Me, Jen Again. Never forget to educate yourself and be your own advocate and save your thyroid.